now is broadcast to the millions of followers on Facebook.
Go to EMS.
Well, I do want to, of course, like to, of course, always open and say welcome to EMS Office Hours, and that I am Jim Hoffman.
I'm Josh Knapp.
And I'm Dave Brenner.
So, guys, gonna try to do a little Facebook interaction today as well. So, want to welcome anyone that might be joining us here in the live feed. Do me a favor, guys, if you are watching this live with us, to be sure to like and share and comment in the Facebook. Hit the little emojis that are down there, but don't hit the emoji with the heart, squeezy heart thing.
Oh, why not? That's a great emoji.
Yeah, don't hit that emoji. So
that's my emoji when I care, but not really.
Right. So,
but not enough to leave a comment. I care, but not enough to leave a comment.
Yeah, we kind of survive on the likes and hearts and stuff like that. It does help us out. So, guys, if you before we start, also I do have the free membership over at Terramedic at the Terramedic, actually at emsseo.com/insider. You can get a free membership there. I say it's free, but I always tell people it's not really that free, because you have to invest the time and the effort and everything to actually put in the work to get any benefit out of the content there. So check that out, and be sure, of course, to follow us here on Facebook. So I did a thing, guys. I did a thing. It was a thing. I shared an image, sort of quote thing. I'm gonna try to put it up here on the screen so anyone looking, and hopefully you guys can see it as well.
Jim, inciting riots is my role.
Yeah. Well, let me know if you guys see that or not. If not, I know Facebook is going to see it, but I want to make sure you guys, if you and Dave don't see it, I'll let you know.
I see it.
All right. So pretty much, I put this up on my Facebook page, on our Instagram page, stuff like that, and I put it on a paramedics on Facebook page as well, getting a lot of likes for it. I think people kind of feel what the gist of this little phrase is, but I'm getting people, of course, taking the other side of that as well, saying that it's not true, that a lot of people are like, people know how bad hospitals are, and they're not going to want to go to a specific hospital because, they know that hospital sucks and the care they're going to get there is crappy. And then other people coming in with the other angle of it where, well, people know that their insurance company is not going to pay at a hospital you might be taking them to versus a hospital they want to go where their doctors are affiliated with. And I guess in some ways, the phrase here is well, first let me verbalize the phrase so people listening to audio know what the hell we're talking about. The phrase is very sick people rarely care which hospital you're driving toward. So in essence, we talk about very sick people. I mean, I've never had somebody who was in severe CHF having a major MI where they were, having a real critical issue ever asked me to take them to a specific hospital. Those people want you to help them. They're more concerned about how are you going to make me breathe? How are you going to make this chest pain go away? How are you going to make this stroke stop happening? They're not worried about necessarily where you're taking them. Okay. Now, granted, in some areas they can have a choice. It doesn't matter, right? Because hospitals are close together. So, of course, you're not going to, if the hospital is 2 blocks from one hospital to another, you're not going to say, no, you're going to the one I want to go to. You're going to take them to where they want to go. And I think what this phrase is getting at is more the which hospital you're driving toward within reason. you know. So have you, I'm sure Josh, you know, I know I get all the time, this is something that would happen. Where I worked in Brooklyn, there were 3 hospitals and everybody wanted to go to the one hospital all the time. And the hospital was always overwhelmed. It meant we were going to get stuck there for, 45 minutes to an hour because they wanted to go there for a medical issue or an injury that had nothing to do with their history or nothing to do with their doctor. And we knew they were going to be, probably in and out relatively quickly, you know. So what do you think? I mean, what's your guys' take on any of this?
Well, it's hard for me to answer that because like you pointed out, I live in a very dense population, and that's the population I serve. And so one hospital might literally be blocks from the other hospital, and
Right.
it's one half dozen of another. Now, as far as I have a couple of comments about the idea of when somebody's, having a massive MI or APE or they can't breathe, along those lines, you're right. But that's sort of what our role is to mitigate that immediate emergency, at least get them to breathe, at least, reduce some of the pain with treatments in terms of what they're struggling with. So they're not able it's like if you fall down, the first thing that you want to do is get up off the floor. So they're trying to just get up off the floor. But I've had patients in that mode where they can barely speak and they're still getting out that they want to go to one hospital over another.
Mm-hmm.
So I'm not sure that I totally buy into that statement unless you're talking about people that are unconscious. Or, and then of course you remember the days when you had a STEMI center. Not everybody was a STEMI center.
Yeah, or a stroke center.
Stroke center, right, exactly. Yeah, so you didn't really have choice. And usually the ones that were more advanced and were the STEMI center or the stroke center or whatnot were usually a better place anyway. So, where family would kick in at that point in time.
And that's something too, right? Very sick people, sometimes they might not even care where they're going, but you've got the family behind you chiming in where to take them. They have to go here, or they don't like one family member doesn't like a hospital because they had a bad experience there, and now they're projecting that on the patient who really could benefit going to that facility because either it's closer or it has the right services there to take care of the patient.
What I used to say is, somebody, and I actually taught this at one point. It's like when you have somebody who is, laying on the ground after a fall or some accident, and this more dealt with trauma, where you couldn't really see the trauma, but the person was complaining of arm pain or leg pain or something like that. And you say, listen, to examine, to really look at this, I'm going to have to cut your piece of clothing off. And I sort of that was sort of a gauge because people who, were really hurt, they didn't give a crap.
Right.
They were like, cut it off. Right.
That'll be the next quote I put up. People who are really sick rarely care if you cut their pant leg.
There you go. That's.
I think part of it, I think some of it is us having to educate the patient, right? And be the advocate for the patient by letting them know that you going to a further hospital in your situation, whatever it is not going to benefit you.
Right.
I don't mean this quote to be like this blanket thing that you go where we tell you because you call 911. Now, some people in the Facebook group they're saying that, don't call 911 if you want us to be a taxi and take you wherever you want to go, but I think there's a sort of like a midline, a kind of some midway to kind of, address this sort of issue,
So I'd like to address that issue.
Go, Dave.
I want to address the issue with the person who we think is not so sick and they want to go to a specific hospital. And let's start with that. that there are some people who are not so sick and they don't want to go to the nearest hospital and they got a preference and they say, my doctor's there, at 3:00 in the morning, their doctor's not there. But
Yeah.
my doctor is there. All my records are there. And I know we have electronic records and we can share them in a blink if we want to. You know what? If they're not so sick, if they're not dying, I'll take them 10 minutes out of the way, 15 minutes out of the way. I will tell you there are limits to what I'll do. I had a woman who was giving birth in beautiful downtown Holbrook who asked me to take her to St. Luke's. Didn't happen. Wasn't going to happen. And I was able to convince her to go to Stony Brook, and the baby was born on Nichols Road. And she told me she wasn't having a baby in the ambulance, and baby came out. And by the way, she named the baby Nicole because the baby was born on Nichols Road. And I told her she could have had little Horace Harding or Kosciuszko if we had tried to go to.
Right.
But the truth is, if they're not so sick, I'll take them, 10, 15 minutes. I'll do that. I don't care. You know why? Because I don't care. If it makes them happy and they're not so sick and it's not going to hurt them, I'll take them. Now, if I was living in a place where we don't have densely population and a hospital on every corner like Josh has, you can throw a softball and hit a hospital from any corner in New York City.
Yep.
If I were further apart, if the nearest hospital is a half hour away and that yet there's another one that's 45 minutes away, then it becomes an issue, or another one an hour away, and then it becomes an issue. And in my head, I'm saying, look, if you always want to go to this hospital, you need to move across the street from that hospital, and I promise you, the ambulance will take you there every time. But no, that's in my head. I don't say that to them.
I was wondering.
That's just a thought bubble that they can't read. And but I'll say to them, listen, you are really sick. You are, I've said this to people, you are really sick. I'm afraid you won't make it if I bring you to that hospital.
Right.
And I've heard things like, we have a lawsuit with the hospital you want to bring us to, or my father died in that hospital.
Sure.
And I have been known to say to people, listen, every hospital has had somebody's father die there. Every hospital has had children die there. Every hospital has saved lives. Really
made mistakes, right?
They do make mistakes.
Of
In
course.
the best of hospitals, they make mistakes. I said, but I need to get you to an emergency room right now where you can be stabilized. And if you're stable enough, you don't give up your rights when you get there. You can have yourself transferred, to that hospital in Ames, Iowa. If that's where you want to go, you can go there later. But right now, when they're really sick, I tell them, you are really sick, and I'm worried that my patient isn't going to make it to a distant hospital.
Now,
And I say that when that's what I feel.
Would you actually tell a patient, with the idea that it may make them even more, symptomatic, let's say if they're having some sort of cardiac problem?
It depends upon.
You might not make it if, because I would probably think if I were the patient, if I'm not going to make it to my preferred hospital, will I even make it to this other hospital?
You may not.
But
You have a person die in the back of the ambulance?
Nobody ever dies in the back of an ambulance.
You do CPR and they get pronounced elsewhere. Listen, I tell them the truth when I have to tell them the truth. When it comes down to it, I say to them, you are really sick. You need to go to the nearest hospital. And if they pursue it, I'll tell them why. I've said on occasion, I'm afraid you won't make it to the hospital you're talking about. All right. Things are very bad. And that's where I'm going to, that we need to take you to the nearest hospital. It's not that I don't want to take you where you want to go. I do. And when I can, and I do this all the time, I give them choices. These are for most people, these are the 2 or 3 closest hospitals. Which would you like to go to? And when they say to me, St. Luke's, that's not happening. And I've had people tell me they want to go to, that cardiac hospital in Nassau County. Right. I said, I can't do that. I can't do that. I'm really worried about you as a patient, and I need to do the right thing. And it's worked. And, for the most, I remember fights when I was young and stupid, arguing with people about, stupid stuff like a 6 minute difference. They wanted to go somewhere, and it wouldn't have made a difference. No, 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 you're going to the nearest. It's not worth it.
Right.
It ends up being, I think, sometimes, Dave, that people like providers start feeling like they're being abused, that they're being treated as a taxi when patients, you walk in the house and it's the first words out of their mouth is take me to XYZ hospital. And I think for me and for Dave, I'm sure Josh as well, that as you do the job for a while, you start realizing you can give patients choices. You can accommodate them. Like you said, 6 minutes, 5 minutes difference is not going to be that not going to make a difference. And if it makes a much difference, you're kind of a crappy provider if you can't, take care of it for the extra 5 minutes in the back of the truck. And when I posted this, I didn't mean it to be like this blanket statement that, it's cut and dry one way or the other. I wanted people to kind of talk about this a little bit because I feel that it's important to kind of sort through the black and white of it, and some of the stuff we've talked about, already, as far as giving them choices, educating them on how one hospital has better services than another, how the doctor's not going to be there at 3 o'clock in the morning, how they do have options if they want to get transferred out after the fact, after they're stabilized in the emergency room. I think a lot of patients feel like once they get to the hospital, they're in some kind of a jail where they can't get out anymore. One thing I wanted to ask you guys.
Well, but the hospitals are part of that too, Jim, aren't they? I mean, yeah. Have you ever heard the statement? Well, because sometimes, and I've been in this situation where I've been in a local out of state hospital, and I felt that the reason that I was there was pretty well satisfied, but they wanted to do more tests or whatever. And I said, no, I really want to go. And then they give me the line, or they give the patient the line, or I've heard EMS give the patient the line. If you leave against medical advice, your insurance won't pick up the bill.
Yeah, I've heard that before.
It's total bullshit.
Yeah,
I've heard.
Go ahead, Dave.
I just want to say before we move on, I've seen the reverse too, where people have gotten really hurt and they want to go to the nearest hospital. And I need to tell them the nearest hospital is not equipped to deal with what with what you need. And we need to travel another 6-7 minutes because it will make good. I'll get you to the nearest hospital really fast, but then they're going to transfer you to this other hospital because that's what you need.
Yeah.
They're not capable of dealing with your emergency. So,
yeah,
I
think that's important. That there is, like I said, it's sort of that flip side of that, right? Where you have that deal where sometimes where they want to go isn't necessarily that far. It is closer, and you have to be the advocate at that point to get them to understand that the next further hospital, a hospital that might be across town, is better equipped for whatever reason, right? And something, Josh, I mentioned about the insurance and paying is something I saw in the group. People commenting on this post was people talking about how one insurance is not going to pay, or because the patient's insurance isn't going to pay because they didn't go to the hospital the doctor was affiliated with. And this is something that I'm kind of torn with because I have to, I wonder, if that's something we should be worried about.
What? Rephrase the question. What
should we be concerned about the patient's insurance and what it's covering and what they're going to be billed for and things like that, or should we be concerned with the care they're getting and what's appropriate for them as far as the hospital choice?
I think that becomes a liability.
Because how do we know? I mean, listen, I don't know. When I was in paramedic school, EMT school, all the CMEs I've taken over the years, education that I've had over the years, I've never gone into the details of how insurance is paying for every ambulance call and what they'll pay for, what they won't pay for, based on the patient's choice, on our choice, on the hospital's billing methods. Is that something that we should be educating ourselves on enough that we can actually make that part of our decision process?
I don't think.
I
think it's a liability issue. I think it's something that we're not equipped to address, and it puts us at a not a disadvantage, but it creates a liability for us if we start trying to make those decisions.
I don't even know. I don't even know if it's true in a real emergency.
Right.
I
don't
would
think
think
it is.
most insurance covers the emergency room that's near you. In
Yeah.
a real emergency, I do
Right.
know. I do know that there were times, and I'm talking before you were born, Jim, when my wife and I were having our first kid, and our first and
Those were
second
the
kids.
horse-drawn carriage days.
We had HIP, the health insurance plan, and there were HIP hospitals, and
Right.
and I will tell you that when you went to a HIP hospital and you had HIP, you paid nothing, not a penny, not a thing. And if there is any truth to people having to pay, I don't know, whatever percentage, 20%, 80%, whatever it is,
Yeah.
these can be devastating numbers.
Oh yeah.
I mean, when I look at the billing practices, and I know our healthcare system is broken. The stuff, I recently went to the hospital because I got bit by a brown recluse spider.
Oh,
Yeah.
Wow.
It could have been terrible. The good news was I killed it in my sleep. I killed it as it was biting me, and I got off really lucky. I didn't know I had killed it until I went back to bed 3 hours later. But
still,
I saw what they billed. I'd have to work for weeks and weeks and dedicate my money directly to them if I was going to pay what they were billing.
Yeah.
And if they're charging that to people who don't have insurance, if I was unfortunately unemployed, uninsured, due to whatever circumstances, I would have been better off getting.
And on top of that, Dave, I mean, you may be aware that the hospitals have separate billing scales, separate billing dockets, so to say. So if you have no insurance, you get the full bill. You get a non-discounted bill if you have no insurance. Yet if you have insurance, because the insurance company has that strength, they've negotiated their payments down. So where you may pay, let's say $2,500 for an MRI, the bill
Insurance company pays $250.
Exactly.
I know.
Exactly.
Impressive.
So I think it's almost that we need to back up and sort of stop at your statement that says our healthcare system is broken, as it is, but to sort of circle back more to the initial question of should we take billing into consideration on a humanistic level. When we have that knowledge, I think that there's an aspect of that we need to follow through with our main goal, which is do the best we can for the patient and take the patient complete, worldview on that. In terms of all the inputs and outputs and what's, how sick are they versus what they have to pay and stuff like that.
Yeah. I mean, listen, even for us, right? We're not worried. We're not even thinking about insurance. If you have a patient that's very sick,
correct,
and you want to get into the last thing you're worried about is what they're going to get billed and all that stuff.
Not even.
That's the last thing we're worried about.
Yeah.
Right.
And they may be worried.
Yeah. That's the thing. So that's where we go back to the original, question of does it, when they have an issue where they want to go to a certain hospital, let's say they're unconscious, like I said before, and they want to go to a certain hospital, and the family's telling you to take them to a hospital because of the insurance issue, is that something that you take into account?
It's the same dynamic of just arriving on the scene and being competent and confident and in a caring mode, and the patients suddenly, like they're having their difficulty breathing. The breathing is getting worse. You enter, the breathing is getting worse. You sort of calm the situation down, and without any interventions at that point or minor interventions, the breathing drastically improves. I mean, we've all had that,
Yeah.
There's the flip side to that as well. that we're not going to solve their, they may have gotten a bill that they can't already pay, and now they're going to the hospital, and we can't solve that issue.
Yeah. Well, let me just change gears a little bit, guys. I want to just kind of wrap it up today on this. I don't want to keep going on. One thing I want to ask you guys is, you see a lot of I'm going to stop sharing this thing here so we can just stare at each other handsomely. There we go.
Hey.
There we go.
Hey guys.
So, do you guys ever? Well, I'm sure Dave has. Josh, I'm not too sure about. Like, you read books on EMS or about EMS. Have you ever done that where you feel you read something that you feel could benefit, the masses, not necessarily a textbook, but a book of stories or a book of tips or a book of whatever,
Yeah.
The urge to go political.
No.
Go, Dave. Take this.
I'm not going political. No, I've read books.
No. I was just.
I mean, Dave, you got a nice book right behind you in the shelf, the AMLS book.
I do.
Right?
I tell all of my students who take the course, because you can't read it in the time of the course. I tell them to put it in the bathroom.
That's something funny that you mentioned that, Dave, right? How many, when you've taken a lot of these courses, you take these courses, they give you this book, and you're like, there's no way I'm reading this book during this course.
Right.
I'm not going to get through it between the what I'm being taught in any exams and quizzes I got to take, skills I have to do. When am I going to be able to get to the part of the book that it might, mean something to me,
Just for fairness, we used to do internal training at the operation I am working at, and the guy who was head of that would say, as soon as you signed up for the course, and generally you had to sign up for the course, they really made it at one point you had to sign up for the course a year in advance. Yeah, but we were doing the CME refresher, so it was a pretty well programmed thing. We knew what we needed to do. It only became a problem if you went out or something like that. But he would give us the books then and just say, look, at least scan the book before you take the course, and that way you'll have some background on the course, and it'll make the course more enjoyable as well. And that was a pretty effective means. It's when you go and sit in a 16-hour course, you're on your first day, it's going to be 2 days, and they hand you the book. It's like, what am I supposed to do with this? I'm in class all day. When I get out, I'm not going to, I just want to get home.
Yeah.
And impressively, we passed those courses in 2 days without ever reading the book. Makes you wonder why we have a textbook.
Makes you wonder about the material.
Well, one thing that I always encourage people when I talk to people about passing exams and EMT classes and stuff like that is, which most people don't do, and I didn't do it when I was in class, right? I started doing that way down the line after being EMS for a while, was to read the content that's on the syllabus for the next day, the day before, so that you had a clue what was going on, and you actually could bring up questions for things that you didn't understand in the chapter, to the instructor while you were there. But so many people do, like you said, they get into the class, they sit through it, and then after class, they don't have time to start reading the book, and then they get into this cycle of struggling to study and struggle to retain the information and to kind of have the building blocks that each chapter is supposed to try to give you. Now they're like 4 or 5 chapters in, they're trying to remember what the hell happened back in chapter 2. And that ends up what happening. One book that I will say I do recommend is this little baby right here, Life and Death Matters. That's not a shameless plug. I'm getting no money for anybody that buys this thing. You can find it on Amazon. I actually did a podcast with these guys, but this is professionalism and decision making for the first responder, and actually a lot of good sort of tips inside of this book that I think people could read it and actually get some day-to-day practical information that they can apply while they're working, to make decisions on scene. Some of the stuff we talked about today, as far as, patients making choices and educating the patient and being the patient advocate and being a professional when you're on scene and stuff like that. And I think that books like this, it's a relatively thin book. You can get through it, in a day, maybe two. And I think it would really, definitely would help. And just something to think about. Like I said, I keep this handy because I look at this book when I'm doing podcasts, when I'm doing, Facebook Lives and stuff like that. And I try to take tips out of this and try to turn it into something that they can apply it to, So I think people would definitely be worthwhile to go ahead and do this. I was wondering if you guys had, books like that you might have come in contact with that you thought might be, beneficial to people. I know this is kind of off the cuff, but I was just wondering if you had any, ideas, top of your head, something you might have read or whatever.
I think there's a host of excellent material out there. And, when you were saying this is something that I sort of keep by my side or refer to and look at, I was thinking, isn't there like an EMS pledge or an aspect of the 6 points in patient care of the Star of Life or that have keep yourself informed, update yourself, keep abreast of new techniques and new things that are happening. I mean, the learning can't stop especially in this career, the learning, and which is another thing for me. Is it a career? But especially in this endeavor, you need to keep updated. You need to keep abreast. I mean, how many of us have an app on their phone, the Hippocrates or Netscape, and they push new stuff to you all the time. I mean, there's new information on a multiple times a day basis.
Yeah.
On stuff between just the major points of cardiac and stroke to, do vitamins work? And this is stuff that we need to always keep in the forefront of our mind. I mean, we need to be fresh on that, because otherwise you're not doing yourself a favor, and you're certainly not doing your patient a favor.
Yeah, so many people get done with class and they don't want to ever crack a book open again. And then they slowly fall behind, and then when they have to refresh, they're like in a panic, because they haven't opened the book since they graduated.
Plus the concept of continuing medical education.
Yeah, and so
not compressed medical education.
Yeah, and even with that, Dave, a lot of people will go ahead and they take these continuing education classes. They'll bypass something that they feel they've heard before. I'm not taking a 12-lead class. I've taken that before. How many times can I see a different 12-lead? Or I'm not taking that class on strokes or MIs, because I've had multiple CMEs on that over the past 2 years. But I always tell people, you take training from different places, different sources. And I always feel that you can always get something new out of it. An instructor will present it differently than the last instructor. There might be you might sit for a 30-minute continuing education and get one image that pops up on that slide deck, or one comment that helps, kind of click things in your head, where it makes some of the stuff you might have been confused about before and puts it all into perspective for you, because it's the way you're getting the information. So I think that it's important for people to kind of remember that, not just kind of give up and, close the book after I get my NREMT. I'm done. I've succeeded. It's not really necessarily the case,
I got 80 on the test.
What's that, Josh?
I got 80 on the test.
I got 80. It stopped at 70. Now what?
Right.
Stopped at 120. What do I do? I don't know. You got to wait till you get the results, So I'm gonna end it there, guys. Oh, one thing I wanted to mention is something. Maybe we can talk about another podcast, but just to kind of end it on the continuing education end of it, I saw something about the increased use or the coming back of norepinephrine.
Sure.
You read about that, Dave, at all?
It's not news. Yeah. It used to be Levophed, leave him dead.
Yeah.
But now it is the go-to drug for medical shock.
Yep.
And how many?
The problem was we were using it for hemorrhagic shock, and that was just
That could be
stupid.
bad.
Yeah, but I've seen some stuff though that's coming out. Like I know it's been coming back out, but I'm seeing more like I guess guidelines and agencies actually adopting it. But I sometimes I wonder why that is all of a sudden back into play. It
Because
just
it works.
but
It works.
But it wasn't not working before.
It was being misused.
Yeah, took a long time to figure that out.
It did. We had to kill a lot of people for that.
Because when I first started in EMS, we had it and it was going out.
I have to say, I think a lot of the changes that we've seen in the last, 10 years in EMS, and I think that that's probably where the changes really started to roll on fast. I mean, if you recall about 4 or 5 years ago, our protocol updates were every 3 months. I mean, they're supposed to be every 6 or every year, and
don't remind me.
They're just rolling out. Right. You especially, Jim. And I think that what has transpired over that period of time, and or at least from a casual observation, has been the seriousness and the respect that pre-hospital care has been gaining in the whole continuum of care for our patients. It used to be bring them to the ER, whatever condition, however you want to get them there, and then the medicine really starts.
Yeah.
And now it's no from almost the point of the phone call. We're looking at every nook and cranny where we can stuff in something that is beneficial to the patient. And I think that's an important aspect that we need to keep in mind, and puts greater pressure on us as field providers to keep up to date on these things.
Right. I mean, well, listen, we're getting paid an exorbitant amount of money to keep up all this education and training and skills, to give this, this pre-hospital care out there. So we should definitely be, staying on top of things. So I'm gonna end it there, guys. I had another topic, but it's going to be way too long to get into. So we'll have to save that for maybe next week. We'll do another one and do that. So I've seen people popping in and out of Facebook throughout our little endeavor here. Again, I encourage people to please hit that little thumbs up button, the little heart button, the frowny face button. I don't care, because it lets people know in the groups that this is getting broadcasted in, that there's a video here, and they can go look at it too. Because, of course, in about 10 minutes when we end this, we'll be buried in the feed and no one's gonna see it. So if you like it and you heart it and you frowny face it or whatever, at least then people know that it's there and they'll go ahead and hopefully check it out. So
well, aren't you a major Facebook advertiser, Jim, and therefore get preferential treatment and bumped up in the news?
Oh yeah, me and Zuck are like this.
Yeah,
like this. I'm the thumb. So.
In fact, those of us who know him just call him Zuck.
Right. Yeah, me and Zuck.
That. Yeah.
I gotta call him later on today and say, hey,
what's
Zuck?
up?
Hey, Zucky. Like that. And he's like, who's this? Stop calling me. Who gave my number?
David.
All right, guys. We'll end it there. Again, everyone, please go check out Tour Medic Insider. It's at emsseo.com/insider. Become a free member there. And of course, check out emsofficehours.com for the other podcasts and content that is there as well. So, all right, guys, thanks for joining me. I really appreciate it. As always, I am Jim Hoffman.
Josh Knapp.
And I'm Dave Brenner.
All right, everybody, stay safe.